you, Dr. Harshul, for including me in this wonderful instruction course. And I'll be, as Dr. Harshul has mentioned, rightly mentioned, that cataract is now becoming a refractive surgery now these days, because we want to provide uncorrected 6/6 vision, even N6 vision. We take care of intermediate vision, and there's so many issues. We take care of the astigmatism, and for that, we use Toric IOL in order to handle the astigmatism. I don't have any financial interest. So the question is why we should handle the astigmatism, why we should use Toric IOL. Because there's a handful of patients, nearly 1/4 of patients who undergo cataract surgery, they have a corneal astigmatism of more than 1.25 diopters, and 10% have 2 diopter or higher. So that's the reason why we want to correct. Now, if they have astigmatism, even if they have a good vision, then there is some amount of, blurring, some amount of less clarity of vision if you compare from an eye without astigmatism. So that is the reason why we have to think of it. But then there can be various reasons to, have astigmatism, and in what all conditions we can use Toric IOL, that's what I would like to highlight here. A patient who has a primary astigmatism of more than one, these days people are considering more than even 1 diopters, you can consider using a Toric IOL. Anything less than 1 diopter, particularly against the rule astigmatism, people may not use a Toric IOL. It should be a regular bow tie astigmatism. Irregular astigmatism cannot be defined, so we cannot use a Toric IOL. Keratoconus, but with negligible or no progression. And particularly, we don't have an issue even in a keratoconic eye, because most of these patients have senile cataract wherein you don't have much progression of keratoconus. So there also it can be handled. Post-keratoplasty eyes, but in such eyes, we have to be absolutely clear that this cornea is going to stay for long. It has a good endothelial count, and the duration is reasonably long, that there is less or absolutely negligible risk of graft rejection. In such a scenario, we can do it, and only after complete removal of sutures and after waiting for some time. Because in any condition like Fuchs or any dystrophy, wherein you have to do a keratoplasty at a later stage, there's no point using a Toric IOL or a multifocal or any sort of premium IOL. It's always better to use a monofocal lens in that. And of course, if there's a posterior capsular bag potential capsular bag instability, in such cases we should avoid. Now, if there is little bit of zonal dehiscence, we can still stabilize it with the help of your capsular tension ring, and then we can go ahead. But if there is more subluxation, it is not advisable that you fix it with Sioni and then you do it, because then what happens that there is some amount of distortion, and that can affect the placement of IOL, that can affect the actual effect of the IOL. So that is an important issue. Patient should be thoroughly evaluated, and Toric IOL is implanted based on the corneal astigmatism. And we can use a manual keratometry or IOL master. These days it is becoming popular, and we use it. We can have all these measurements, SimFlug, measuring anterior and posterior corneal surface, because it is a known fact now that posterior corneal curvature can have some impact on it. And posterior cornea acts as a minus lens, and it affects with the rule and against the rule differently. So the general rule is this, that if you have any degree of primary astigmatism, then you measure the astigmatism, and then you decrease the corneal astigmatism by 0.5 diopter if it's a with the rule astigmatism, and increase corneal astigmatism by 0.3 diopter if it's against the rule astigmatism. And what we do is calculate spherical power just like any other by any standard formula, and then we calculate the cylindrical power by Toric calculator. So this is one of the Toric calculators. There are various calculators. I'll just come to comparison of all these calculators. the ACRYLIC Toric calculator has all these findings. So what data you have to put in, that is written here: preoperative manual keratometry, IOL power, incision location, and estimated surgically induced cylinder. Now, this is one example wherein you have to put flat K, steep K, axis, then surgical power, what is your that is surgeon-specific surgically induced astigmatism, and incision location. Now, what is incision location? Now, if it's a right eye and you are doing a temporal phaco, then it is 180 degrees. And if it's a left eye and you are doing a temporal phaco, then it's a 0 degree. Now, what is surgically induced astigmatism? You check your own surgically induced astigmatism, like you do multiple surgeries and then you put the data in this chart. So this is a SIA calculator: pre-op K1, pre-op K2, axis 1, axis 2. Then after the surgery, post-op K1, post-op K2, axis 1, axis 2. And then you create. And this way you keep doing in as many patients. If you do 100 patients, you will have a reasonable estimation of SIA. If you do 1,000 patients, you will have even more accurate SIA of your own surgery. And that again depends on the size of blade that you are using. So if you are using 2.2, based on that you can calculate SIA. So everything has to be done based on the same instruments. The keratometry and all these measurements have to be done in the same instrument so that you don't have any variation. So this is how you do it. Now, this is the output screen. So once you have entered all that, you get this value. So this is the spherical equivalent, this is the power, this is the model, this is the cylindrical power at the IOL plane and at the corneal plane. There are various calculators. This is the ACRYLIC calculator that I showed. There's Hoya Toric calculator, which takes into account the AC depth as well. The Barrett Toric calculator is there. We have based on some studies, people have found out that Barrett Toric calculator has been found to be most accurate. However, you can use other calculators also, because the accuracy is at the of the range of say 0.2 diopters or 0.25 diopters, and most of the times, even if you have there is some error of 0.2 diopters or 1.15 diopters, that doesn't cause any significant change. So Barrett, although is the most accurate calculator, but you can use other calculators as well. Then another method of evaluating and putting the Toric IOL is a VERION reference unit. Now, in a VERION reference unit, you take a picture, you capture the image of the patient's eye, the scleral vessels, the limbus, and iris features. And this is a sort of an image or a fingerprint kind of a thing, which is transferred to the attachment of the microscope, and you don't have to mark the eye. You just take the patient to the operation theater, and based on that, based on whatever the data has been transferred to the microscope, you will see the axis while doing the surgery, and you can place the IOL in that axis. Now, one thing there are a couple of things you have to be a little careful in placing the IOL, because sometimes you get a little bit of parallax while you are putting the IOL. That one axis will be looking right bang on target, the other will not. So there are various factors due to that. There are various factors due to that. One of these is even the centration of rhexis, then even the eye placement, like the position of the globe, and all these things are very essential. So centration of IOL is also very essential in these, in order to have minimal no parallax, and we just have to, and centration of rhexis, as I said. So all these factors you have to take into account, and then you can place the IOL in position. Now, there are various models of Toric IOL available. You have the ACRYLIC Toric IOL in T3, T4 up to T9. You have Technis Toric. Then you have other Toric, Hoya Toric, and all these IOLs. They are coming up with Toric IOLs because Toric IOLs have shown the best results amongst all the premium IOLs. And even if it may be considered a off the record kind of statement, but it's a practical statement that what I have found out that I have, placed the IOL based on, I have calculated the chart or axis placement based on multiple toric calculators. There was some difference of 5 degrees or 7 degrees in between the calculators. I followed one, and still the patient has 6/6 vision, and he was having crisp vision. So little bit of 2 to 4 degrees here and there doesn't affect the patient's quality of vision much. So that is one thing. Apart from that, I'm just finishing. Apart from that, once you have placed the IOL in the proper axis, although having said that, the IOL axis should be, the axis should be properly maintained. That is very essential in order to have good results. But 1 or 2 degrees is not going to change much. This is something which I found out. So I felt it's a forgiving lens. It's not that bad. And in order to keep the IOL long term in its position, there should be a good adhesion of the capsule with the IOL, and the hydrophobic acrylic lens have the best adhesion with the capsule. So this is the type of IOL as far as material is concerned. This is what we should select in placing the IOL in its position. So thank you very much for your patient listening, and if there are any suggestions, any additions, anything from the panelists or from you all, I'll be happy to accept that.
Dr. Sinha, that was a wonderful presentation. Now, basically, lots of us are doing torics.
Mike.
Hello. Now, lots of us are doing torics, and like you highlighted, the significance of posterior astigmatism is growing more and more day by day.
Yeah.
Lots of us still don't understand how to incorporate. Number one, how to assess the posterior astigmatism, and how to incorporate that posterior astigmatism in our final values of toric calculation.
So, I had mentioned that actually, that there's a general rule. Many times, if you don't have access of Schimflug imaging, or if you cannot calculate the posterior.
So, number one, what are the ways we can calculate? Which instruments can calculate posterior astigmatism? What are the instruments in the market today?
Well, Schimflug imaging is the best to.
Is one option, which is pentacam. Okay.
This is the best way to calculate the posterior astigmatism.
Okay.
Yeah. So we can do that. But apart from that, even if we are not able to calculate posterior astigmatism, there's a general rule that if you have got the with the rule astigmatism, you subtract 0.5 from that, because this posterior toricity in most of the cases has its effect in the against the rule axis. So what happens that, and it affects it differently. So there's a general rule that if you have calculated the keratometry, done the keratometry, if it's with the rule astigmatism, then you subtract it by 0.5, and if it's against the rule astigmatism, you add by 0.3. This is a general rule. So even if we are not able to calculate the posterior keratometry, there's no problem in that. We many times many places there may not be facility of doing that. So we should have the option of a sort of a nomogram kind of thing. So this is something which we can do even if we don't measure the posterior cornea.
And then what about this role of true K? That means you take one.
That is the true K actually, because most of the times when we calculate, when we do the keratometry, that's not the true K. That is an estimate of the anterior corneal surface. So the true K means that you have to taken care of the posterior astigmatism also. And then once you have taken care of the posterior astigmatism, then you get the true K. So that is the net effect of the astigmatism, which is from the anterior surface as well as from the posterior surface.
And Dr. Rajesh, thank you for excellent presentation on the case selection and preoperative workup on toric lens. You mentioned a very important point about the hydrophobic lens, which causes shrink wrap effect, which is very important to provide the long-term refractive stability of toric lenses. I want to ask you that most of the manufacturers, IOL companies, are making hydrophobic acrylic lens, with the exception of Rayner lens, which is hydrophilic lens. So do you have experience of implanting Rayner toric lens, and any comment about its long-term refractive outcome or stability in the capsular bag?
Well, Normally I don't use hydrophilic lenses, so I don't have any experience of Renner lens. I usually use the hydrophobic lenses only. And another thing which I forgot to mention is that, in order to have a long-term stability in the same axis, it's very essential to remove the viscoelastic from behind the lens. That is one thing, so that it sticks. And I normally use, in all the cases, whether it's toric or it's a monofocal or multifocal, I use hydrophobic lenses only.
Thank you.